Hello, friends. Hey, this is Dr. Desmond Bell. Um, Unfortunately, we had some technical difficulties during the original presentation that I gave as part of Wound Awareness Month. So I'm happy to present the material again. Unfortunately, we won't have the ability to answer questions live, but I think that the essence of the presentation will still be here. Um, you should have access to not only this, but also the actual presentation deck. Dr. Mitchell has received that from me, so she is more than happy to distribute it to everyone. But anyway, I just want to say I really truly enjoyed meeting with everyone yesterday. It was I think, a great session, and I appreciate the opportunity to discuss Omeza and the technology. And I think as you get to use the product, become accustomed to it, I think you'll really appreciate where it came from and why it's going to be successful in your efforts using it. So with that, I'm going to turn off my camera now. I'm going to try to, well, maybe not. Anyway, let's get on with it. Again, I'm Dr. Desmond Bell. I've been a wound care provider for over 25 years. And obviously, I've visited the Bahamas several times over the years. I've had a chance to meet a number of you. We've done work with the Save a Leg, Save a Life Foundation. And I've got a chance to spend time with a number of you have visited the hospital several times now, and it's always been a pleasure. So I truly appreciate everything you all are doing. I want to be considered as a resource for you too as well. If there are questions, you can always reach me. I'm happy to answer them. My email address is dbell, so that's D as in Desmond, Bell at omeza.com. So dbell at omeza.com. Anyway, with that, let's get on with this. Dr. Mitchell asked me if I would talk about the application of Omeza. So with that, I'll give you an overview of what the product is. And one of our earlier discussions that I was involved with, I remember a question came up about bush medicine. And I think that was really a fascinating topic because so many of the pharmacological medications that are on the market and even alginates are derived from plant-based sources. Omeza had its origin in my clinic in Jacksonville, Florida. I began working on this in the year 2009, and I was introduced to a brilliant chemical engineer whose expertise was wastewater purification and surfactants. And why this is relevant is, well, wounds are dirty. And so how do we clean them up? And if we can do it without using chemicals, and if we can give the body what it needs to do its job, then we're on to something. I always like to think that the human body is an engineering marvel, and it truly is. And it was designed to heal itself. But also remember too that healthy people do not develop chronic non-healing wounds. So to be a good wound care provider, the first and foremost thing you have to do is be a good medical detective. Try and determine what the underlying causes or medical conditions are that are making this patient subject to having this wound that's just not moving along or healing in a timely fashion. So, that was part of our approach as we were developing Omeza. Again, this came from a clinical perspective, and we know the things that patients deal with, but we also know that there is a void. Even though we've had technological breakthroughs over the past 25 years, there's still this void. And when I say that there's no silver bullet, there really isn't. Every wound is different. Even on the same person, people tend to have multiple wounds. Sometimes several of the wounds will heal, others won't. So each wound is unique. And the whole idea is, look, the body, again, knows what it needs. So if we supply the body with the components that are necessary for tissue repair and wound healing, that would be a good starting point. So with that, let me explain a little bit about what Omeza is and, again, our concepts. So you can see, looking at this, there's this product with those yellow stripes. So OCM stands for Omeza Complete Matrix. And you'll notice that those strips, they're actually sort of a pasty type of consistency. And this is important because the product itself is a solid, and you apply it into the wound, and then it starts to melt and takes on the shape of the wound. So we'll get into that, but that's a quick overview. I just want to let you know what Omeza is not, though. OCM is not a skin substitute. Be very clear on that. Also, it's not a collagen product. Even though some of its components were derived from fish collagen, there is no collagen in the product. And most importantly, too, it's not a dressing. This is far more advanced than simple dressing. You know, a lot of dressings basically are placeholders. Even some of the cellular tissue products, the cellular tissue products only work when the wound's already healing. So, a lot of what we put in the wound is essentially probably the least important part of the equation. And I go back to that point that, the body is designed to heal itself. So, if we tune the body up to do its job, it will take care of the rest. Applying something to the wound is it's important for sure, especially in terms of keeping bacteria under control and while the wound is healing. But again, there's nothing that you can just put into a wound and just let it sit there and it's going to make much of a difference unless you're addressing other things. So what is Omeza? Again, OCM, it's the first of its kind. It's a drug device, and we'll explain exactly what a drug device is in a second. But the whole idea is, again, to provide comprehensive therapy to address all types of wound from head to toe. And, our starting point as we were developing this, the idea was, look, okay, there's all different types of wounds. You've got diabetic ulcers, venous ulcers, pyoderma, all sorts of things. And those have different etiologies. But if you look at each wound, even on the same person, every wound has certain things in common. And our starting point in developing this was chronic wounds all have edema, they have biofilm colonization, and they have decreased localized perfusion. So our idea is if we can address those three things as a starting point, we'd be onto something. And from that, we looked at omega fatty acids from fish oils as being a start, because omega fatty acids, whether it's omega 3, 6, 9, they have very, very strong anti-inflammatory properties. So that was our way to start addressing the problem of chronicity and chronic wounds. The other thing is, though, we didn't want to be putting chemicals into a wound. We wanted to make sure that there was no cytotoxicity to repairing cells. But also, from a clinical perspective, I look at this one example. I had a patient many years ago who was a foster mom, and she had a fourth grade son that she was fostering. And he actually became a lot of the caregiver. He did dressing changes at home. And as we were developing this, I said, we have to develop a product that can be so easily applied that even a fourth grader could use it in the home. And so we've tried to stay true to that. Even though on the surface it looks like it's pretty simple, it's actually quite complex in the chemical composition and what's happening as the body absorbs it. So anyway, it's a pharmaceutical grade time-released elements in our formulation. And that's really what OCM is. It's a drug device and it's a formulation. So with that, I'll kind of explain some of the components and what they do. Again, I mentioned this. You can use this product from head to toe, any type of wound except a malignancy. And if you haven't biopsied a wound that's been there for quite some time, it's a really good idea. It's not technically difficult to do a biopsy. If you have a scalpel blade or a punch, recommend that you just take a little bit off the leading edge of the wound and then a little section in the central part of the wound. Send those off to pathology. And what you want to make sure is that the wound, if it's been there for a long time, like over 6 months or a year, that it hasn't converted into a malignancy, or more importantly, that you haven't overlooked the fact that it could be a malignancy. A lot of wounds, especially venous leg ulcers or even diabetic foot ulcers, can be misdiagnosed. I've seen it time and time again. So anyway, it's always good to get more information. We take wound cultures, and that's a simple thing to do, figure out what bacteria might be present. Well, you take a look at the cells too, and that will help in determining the course of treatment. Again, anywhere on the body. And the beauty of this is, too, the product can be used from day one. You don't have to wait for 30 days. Now, in the United States, before somebody can use a cellular tissue product, you've got to wait 30 days before you can apply it. This product, because it's not a skin substitute, number one, it can be used from day one. And why that's important is that we don't want wounds to turn chronic. If you can put something into the wound that will help speed up healing, that's a good thing, because the longer the wound is open, the greater the chance something bad can happen. So we're trying to be proactive versus reactive in all this. So again, why wait for the wound to be chronic? And that's a good thing. There really truly is no standard of care in wound care. Wet to dry gauze is probably considered the standard of care, but wet to dry gauze does not heal a wound. So again, it's a placeholder. So again, as we're looking at this, as I mentioned, the body is designed to heal itself. Chronic wounds are really a symptom of underlying issues that must be reversed, whether they be vascular, nutritional, pressure related, connective tissue disorders, underlying chronic DVTs is another one. There's so many things. So the point is, though, that you can't apply one approach or solution to all wounds. We get lucky a lot of times. Eventually wounds do heal, but they were probably going to heal anyway. So that's why I kind of de-emphasize some of the things that we put into wounds. It's so important to address those underlying issues. So therefore, wound healing, though, must be customized to address the needs of the specific wound and the patient. I mentioned nutrition. In the years of my practice, I rarely had a patient who was well nourished. Even some really large people, if I looked at their nutritional indices, they were often lacking in protein, or their albumin levels were low, pre-albumin, iron, any number of things. So, again, it's not just perfusion; it's a multiple group of factors that have to be considered. So, typical issues of all chronic wounds, as I mentioned, the edema, the decreased blood flow, and the biofilm colonization. So I mentioned Omeza is a drug device, and it's novel. There hasn't been any technology like this to hit the market since I've been in the wound care community. It contains components that are necessary, and a mnemonic that I came up to help me remember things over the years was, okay, what does new collagen need to synthesize, or what do wounds need for tissue repair? And I came up with a mnemonic. I call it PACE-Z. So P-A-C-E and then Z. So P is for protein, A for vitamin A, C for vitamin C, and E for vitamin E, and Z for zinc. So that's a basic starting point. And we have all those things in our formulation. But anyway, I showed you those pictures of the strips earlier, and I'm going to show you how the product is actually applied in a few minutes. But it's got the consistency of a paste. Now, the product itself is a solid, but it's called an anhydrous solid. What that means is there's no water in the formulation. It's all oil-based, and there are other nutrients in there, but primarily it's oils. And so remember, oil and water don't mix. But also remember that bacteria, fungus, yeast, all love water they need water to thrive. So what we're partly doing with Omeza is, when you apply it to the wound bed, you're creating an environment that is not conducive to microorganisms growing or proliferating, but you're also maintaining the slightly moist environment that's needed at body temperature for the wound to proceed in optimal healing. So again, the key components, though, are omega fatty acids, peptides, and nutrients from plant and fish sources. So I mentioned this, it's a drug device. So the drug in Omeza OCM is actually cod liver oil. The FDA in the United States classifies cod liver oil as an over-the-counter drug. So that's why we're designated as a drug, or the drug part of it, of the drug device. The device, though, is peptides. Now, a little bit about peptides. What are they? These are microscopic particles that have been broken down from collagen of the fish skin. And the peptides are essentially the building blocks for the body to build its own collagen. So here's what we have here. if you take a collagen product, any collagen sheet, or anything that contains collagen, and put it into a wound, you're putting it into a hostile environment. You've got MMPs, which will break down the collagen. You've got elevated body temperatures, which also help denaturize the product. And then moisture. The Omeza peptides that we are introducing are absorbed by the body. They're so small that they are basically not going to be influenced at all by any enzymatic breakdown or MMPs or body temperature. So, what we're doing is getting these building blocks into the body. They're absorbed, and now the body can start to develop and manufacture its own collagen. So that's a big difference. And peptides actually have antibacterial properties as well. So it's really well thought out. So, you're probably familiar with the healing phases of wounds. And again, I've talked about the acute wounds, why it's important to get something advanced into an acute wound so you can prevent that conversion into a chronic wound. Well, why is a wound chronic? Well, obviously it hasn't moved, but it's stuck in the inflammatory phase. And what is one of the components of the inflammatory phase? Over the years, we've learned that biofilm colonization is probably the biggest culprit. So, a wound's chugging along, but it's not healing, and bacteria starts to get in there and colonize. And especially in somebody who's compromised, maybe because of diabetes or they're on immunosuppressants or something like that, the body's just not moving at a really optimal pace in terms of metabolic activity. So now the wound stalls. And what happens is it sits there. Now it starts to become more susceptible to bacterial colonization. So, and if you look at bacteria that you find in wounds, there are really two different types. And I'm not talking about the type of organisms. I'm talking about the difference. You've got planktonic bacteria, which is bacteria that tends to settle into the base of the wound. That's easy to remove, and antibiotics will work on those. But then you've got these biofilm colonies, which have a surrounding barrier around them. They have, among other things, a glycocalyx wall that prevents them from basically being affected at all by antibiotics. So the only way you can really get rid of a biofilm colony in a wound is you've got to do a debridement. You've got to physically excise it from the wound. But then you've got to treat that area, because any cells left behind will start to proliferate again. And now biofilm colonies start to regenerate basically after 12 hours even. So it's so important to be aggressive. So again, biofilm colonies are totally immune to antibiotics. Doesn't matter if they're IVs or orals, it's not going to work. You've got to hit them with multiple modalities to start to get the wound moving again. But again, it's these wounds that have biofilm colonies that are the ones that are stuck in that inflammatory phase. We want to move things to the proliferative phase where new collagen can start to synthesize again. And again, usually when you first cut yourself, let's say, your body's response is it starts to bleed. And in doing so, you're starting the healing process. The blood carries oxygen and nutrients and growth factors to heal. But it's those wounds that start that just are stuck. They're the difficult ones that we want to convert and get them moving again. Ultimately, you want to get into remodeling, and that remodeling phase can take up to even 2 years on a wound that's healed. Going back to the inflammatory phase, when you see a wound that's been really chronic and has not moved for months or sometimes years, it's truly stuck in that inflammatory phase. So there's no timeline as to how long an inflammatory phase can last in a wound. I've had patients with wounds that have been there for over 20 years. So definitely difficult to manage. So as mentioned, OCM is an amorphous solid. Again, when you apply it into the wound bed, let it sit there for a few minutes. You apply it in strips, and as it starts to warm to the body temperature, it'll start to liquefy and it'll start to then take on the shape of the wound. And it can be used in tunneling wounds as well. Again, anhydrous is important, as I mentioned, because of because bacteria loves water, but also the oils are going to repel other water too. So it's really important when you are cleaning a wound, and if you're considering using Omeza, clean the wound, but then make sure that it dries adequately before you apply the Omeza, because oil and water don't mix, and you want to optimize the absorption of the product. Again, we're rich in omega fatty acids, other nutrients, and again, easy to apply. We're a 510K device, so in the United States, this means that the FDA has already cleared us for selling. Again, the drug is cod liver oil. The device is the peptides. Other components besides vitamins A, C, and E. Vitamin D is one of the things that cod liver oil is rich in. Vitamin D deficiency, I know in sunny climates is not as common, but vitamin D we're finding is so important for wound healing. And so we're rich in vitamin D. Other things that we've got, medium chain triglycerides. Caprylic acid is a strong antibacterial component. Monolaurin is another one. When a baby is nursing from its mother, the mother is passing monolaurin into the baby. Monolaurin is the antibacterial product, or the bacterial component, of mother's milk. So this is a well thought out formulation, I will say. So I'm going to show you a quick little video now, and this will explain a little bit more about how to apply the product and what dressings to use and what dressings not to use. You can also find this video on YouTube as well as on the Omeza website, Omeza.com.
Hi, my name is Dr. Desmond Bell. I'm the Chief Medical Officer for Omeza, and today I would like to share with you how I use the OCM Wound Care Matrix for chronic wounds. OCM is the first of its kind wound care matrix that provides comprehensive therapy for all phases of wound healing. Comprised of cold water fish peptides and pharmaceutical grade components chosen for their antimicrobial yet non-cytotoxic properties. OCM is a malleable sheet that helps to inhibit biofilm formation, decrease inflammation, increase proliferation, reduce edema, and support remodeling to support the patient's natural healing process. With no prep work or refrigeration needed, OCM is ready off the shelf. Prior to application of OCM, prepare the wound bed using standard methods to ensure the wound is free of debris and necrotic tissue. If using a wound cleanser, ensure the wound surface has dried adequately prior to applying OCM. To apply OCM, snap or cut open the tip of the device. Slowly squeeze the contents directly onto the wound bed in stripes or onto a suitable applicator, for example, a tongue depressor. Use an applicator to distribute the product evenly across the wound bed, forming an in situ graft or sheet. Remember to always handle OCM using aseptic techniques. After applying the OCM, allow 2 to 3 minutes for the product to warm to body temperature. This time frame will allow for the transition of the amorphous solid into a more malleable sheet, resulting in optimal coverage of the wound surface and absorption. After applying the OCM, cover the site with a non-adherent dressing. Do not use dressings that contain silver, iodine, or other chemicals such as alcohol-based stains, as these products may alter the chemical composition of the OCM formulation. Some dressings may require steri-strips to keep dressing intact and to minimize the potential for disruption. Lastly, apply an appropriate protective outer dressing, compression wrap, or offloading method as determined by the wound type and the preference of the clinician. The duration of treatment and reapplication frequency is determined by the physician and will depend on the condition of the patient as well as the level of wound exudate. Typically, you can expect a once-a-week application of OCM. Each OCM device is for single use. Always check contraindications before use. If infection, allergic reaction, pain, or swelling occurs, remove product and discontinue use. OCM is indicated for use for a variety of wound types from head to toe, including partial and full thickness wounds, pressure, venous, and diabetic ulcers, tunneling or undermined wounds, and surgical and trauma wounds, and is designed to help decrease inflammation, inhibit biofilm, and increase circulation. To learn more, visit Omeza.com, or if you're a patient, ask your healthcare professional if OCM Wound Care Matrix is right for you.
Okay, so you see that it's very easy to apply the product. Each, I should say, the OCM comes packaged in individual vials that are about 1.6 grams of product. And as you apply it, you'll notice, again, its consistency of paste, but it will start to warm up. Less is more. It's not necessary to spackle the entire wound with the product. Allow it to just kind of settle. You spread it around, and you'll have better coverage that way. It'll be better absorbed that way too. The amount of product in one vial will probably be enough to cover a wound of approximately 16 centimeters squared, maybe 18 centimeters squared. It really depends on the volume of the wound and the depth. Obviously, we're not dealing with just two-dimensional flat wounds. So, but the point is that you can apply, and it's not necessarily to cover the entire thing with a thick layer. Just those strips, spread it out, cover, and you should do fine. Also, frequency of dressing changes. You can apply the product once weekly and have the patient come back. You can apply it more frequently if you deem necessary. It's a clinical decision. In the U.S., because of the vitamin A content of the product, we're limited to 2 vials per patient per day. You can do 4 vials per week on the same patient. So keep that in mind. I'm not quite sure what the regulations might be in the Bahamas, but keep that in mind. Very, very low chance of somebody becoming toxic or having a toxic reaction because of vitamin A, but we're just following guidelines and being extra cautious. So the point is, though, that you don't need to change this every day. We designed our clinical trials so that the patients are seen once a week. So we've conducted trials on diabetic foot and venous leg ulcer, among others. We've also done some independent clinical evaluations and compiled that. So be on the lookout for multiple publications that will be forthcoming. One of our other publications that will be coming out was through the University of Miami. That will be in the International Wound Journal. So they did in vivo and in vitro studies on our product to look at our antibacterial properties. So we're very excited by what they find, and I'm going to share that with you in a minute. But back to the type of dressings that you would use with OCM. Again, you just want to cover something that's non-adherent, whether it's adaptic, a silicone Xeroform, a Telfa pad even. You can use it in conjunction with negative pressure wound therapy, a total contact cast, compression wrap. You don't, however, want to use it with calcium alginates, number one, because the calcium that's in the calcium alginates will bind to the peptides, and it will decrease the efficacy or the absorption of the peptides into the wound. So no calcium alginates, no hydroferroblue, which has got an alcohol stain in it, no silver, and no iodine, because again, these 3 things in particular have chemicals in there that will potentially disrupt the chemical composition of our formulation. And lastly, you want to apply some type of an absorptive dressing over the secondary dressing. I recommend a foam if you have access to that. ABD pads are fine if there's not heavy draining, but if somebody's got a heavily exudated wound, sometimes the ABDs will pull in the moisture, but then they'll deposit it back into the wound. It's kind of like a soggy diaper, so you have to be careful of that. So anyway, but I understand, we don't always have resources available to us, so you have to get creative sometimes. So as I mentioned, we did antibacterial studies at the University of Miami. We studied our product against MRSA and Pseudomonas, and we also compared it to Aquacel AG. And so we outperformed Aquacel AG, and we absolutely validated that we were antibacterial. So again, these are some of the highlights. This was in vivo. We actually, or they actually created wounds on a pig and inoculated the pig with either staph or Pseudomonas. And so very, very encouraged. They were very excited to see what was going on. And again, because there's no antibiotics here and there's no chemicals involved here either. So what that means is there's no chance of cytotoxicity, and there's also no chance of antibiotic resistance in all this too. So that's an important thing. Um, Again, we talked about this already, so I won't go into this. I suspect that there may be some benefit in pH reduction. Chronic wounds are basic in their pH, usually around maybe 8 of a pH of 8. And so you want to get down into a range of anywhere between 3.5 and 5.5 for wounds to heal. So there are acids in our product too, naturally occurring acids, fatty acids among others, but caprylic acid, and these are probably helping to reduce the pH, which in turn helps to get the wound moving again. I mentioned, these antimicrobial properties, but these are some older or some research that's already been done. Fatty acids inhibit biofilm development, and how they do this, there's probably 4 mechanisms of action that have been identified. Number one, they affect the ability of the biofilm colonies to adhere to the surface of whatever product, whatever surface it is. One of the big problems with, let's say, knee and hip implants, as an example, is biofilm colonies can form on the implants, and this is why sometimes these procedures have to be redone, or an implant has to be removed. The wound just will not heal, the surgical wound that is. So anyway, it's this adhesion to the surface is so important. But also by changing the cell membrane fluidity, reducing extrapolymeric substances, or forming fimbriae or hyphae, and modulating quorum sensing. Interesting, one of the components in the formulation is sea salt that comes from the Caribbean, and it comes from a volcanic trench there. It was actually chosen by my chemical engineer colleague for specific reasoning, that we know that there's some signaling that's involved in wound healing as well. So that's just an aside, but again, the key thing is going natural, no drug resistance, and the fatty acids have not only antibacterial but anti-virulent and antifungal properties as well. So I just touched on this, so I'll kind of go through this, as we've already been here for a half hour now. But just to kind of wrap things up, I just want to share with you a couple case studies and some additional research that's been going on. So a diabetic foot small trial was conducted at the University of Toledo and ProMedica Health System and the Jobs Institute. Dr. Richard Simon, who is a very well-known figure in the wound care community, is a plastic surgeon, has done some amazing work up there over the years. But Dr. Simon led a DFU trial there, and after about the third or fourth patient, he called us and said, "Listen, we're already sold on this product." And we said, "Well, no, we want you to finish the trial." So basically, this slide needed to be updated. We found that with the patients that were treated in this study, greater than 90% healing at 12 weeks. And these were all recalcitrant diabetic foot ulcers. And so these results are going to be published in the Journal of Wound Care. That will be coming up probably within the next couple of months. You should see that. But these are some of the photos from the trial. To me, the ones that are most impressive in this are the heel ulcers on these diabetics, just because the heels traditionally have a difficult time healing, not only because of the diabetes and the decreased perfusion, but anatomically, once you get below the surface of the skin, now you're into fat and then bone. So, these wounds do not generally heal from the bottom up so easily. They've got to heal from the periphery as well. So these two patients that you see at the on the lower part of the screen, and here and then over here, these are significant heel ulcers that could easily have gone to amputation. So, really, really well done study. Now I'll share a case study with you. This is a very, very common type wound, although it's not the most common area to find a venous leg ulcer. I'll explain why. But this is a 56-year-old Hispanic male. His past medical history was positive for hypertension, hypercholesterolemia, and venous stasis disease. Now, when he presented to the wound clinic in Staten Island, New York with this, he had already had this wound on his left leg for about 7 months. It had failed prior therapy with silver alginate and also amniotic products. He had good arterial flow. His venous duplex and pulse volume recordings were normal. And so Dr. Michael Lacqua, plastic surgeon there, did this case study, and he applied Omeza once a week and applied a 3-layer compression wrap. So this is what the wound looked like on the first day of treatment. And again, this is after 7 months of failed therapy. But you see the hemosiderin deposition, so you've got this venous hypertension, even though the wound is not found in the medial ankle area or the lateral ankle. It's still got the venous component. But if you see this yellow area here, this is very likely a biofilm colony that's been sitting there. You don't see any other real signs of infection though. So again, Omeza was applied, and after 1 week, the wound looked like this. And you see granulation, no more presence of that yellow tissue. There's also pink epithelialization that's occurring at the periphery, and no other clinical signs of infection. And the wound is closed down by almost 17% in 1 week. After 2 weeks, now we're down 42% almost, and that yellow line that you see there is indicative of how large the wound was at one time. By week 5, completely healed. So this is 4 treatments, and this was after 7 months of failed therapy. This is another case where the patient had extensive failed therapy. This gentleman tried to self-treat for a little bit before he finally presented to the emergency department at St. Michael's Medical Center in Newark. He's got a history of venous leg ulcer that is the result of a couple factors. Number one, he's got a chronic deep venous thrombosis. He's also got a condition that is genetic called factor V Leiden. So he's got this hypercoagulability of his blood, which further makes it easier for clots to form. But he's also a smoker too, so you've got all these bad things going on here. And he presented again in July of 2020, and he was taken to the OR he was admitted first, then he taken to the OR, given IV antibiotics, underwent debridement, and then received cellular tissue products while in the hospital. But unfortunately, things did not progress. So that was in July, but what you're looking at on this photo here was actually November of that same year, of November of 2020. So the point is that he had already failed 7 months of therapy. So once a week application with Omeza and mild compression wrap, and you see complete resolution by week 11, so 10 treatments with Omeza. So again, this is pretty fascinating in my mind, because why was this not healing? Simply laying a cellular tissue product over a wound is not going to move things along. It'll work for a bit, but unless you're constantly addressing those underlying needs, you're going to stall out, and that's what I think happened here. One more for you. This is a sickle cell patient who, as you're probably aware, sickle cell patients can be among the most unfortunate and really difficult wounds to treat. This is a woman who had sickle cell ulcers on her leg also for 7 months, had also had failed therapy. But complicating her situation was the fact that she smoked cigarettes, half a pack a day, also asthmatic, and medications that she was taking to manage her sickle cell included hydroxyurea. Now, hydroxyurea has been known to inhibit wound healing and new collagen synthesis, but also use of opioids can inhibit new collagen synthesis, as well as steroids. So, you don't want to typically put steroids into wounds or have patient on steroids because the steroids will inhibit new collagen synthesis. So, she's got all these things working against her, and had failed therapy. And at this point, she most recently had failed an additional 8 weeks of a cellular tissue graft. So they finally said, okay, nothing else is working. Let's try Omeza on this. So what you'll see in approximately 6 weeks, she was completely healed. 8 weeks, there's already significant remodeling going on. And most importantly, her pain level, which had been a 10 out of 10, dropped off dramatically by about the fourth week, and by 6 weeks completely resolved and no longer needing pain medications. So with that, yesterday we were able to answer some questions live. We don't have that luxury right now, so I did throw in one last little case study for you, and I show this because it doesn't look like a very, very complicated wound, but still, this is often the pathway to amputation. Somebody with diabetes, they've got neuropathy, they don't have feeling in their feet, their toes start to contract, so they get hammer toes, and they walk, and the pressure on the tips of their toes is not recognized by them, so they rub up blisters. Now they've got an ulcer on the tip of the toe, and again, the bone is sitting right underneath there, so it's easy to get a bone infection or osteomyelitis. So this is an instance where my patient presented to me, and she had multiple comorbidities, and I treated her with Omeza. You can see that first day, that middle slide on the top there, this is after I debrided her, and the wound looks fairly clean. So I put the OCM on there, put her in a bulky dressing, and 5 days later, she was completely resolved. So the point is, yeah, this wasn't a typical chronic wound that had been sitting there for weeks and weeks, but it kind of goes back to that idea, if we can intervene early, be proactive, we can prevent some of these wounds from turning into chronic wounds, and that's part of our job too. So with that, I want to thank you all again for everything that you do. I completely get it. Again, I'm one of you, I like to say, because I've been in this community for over 25 years. I know the struggles you go through. I know sometimes you feel like you're the only one who cares, or you feel like you're beating your head against the wall. And that's why we have to lift each other up and be a resource for each other. So I hope I can serve you better in that regard too. If you have any more questions about Omeza, feel free to reach out to me. I'm excited knowing that the product is now going to be available in the Bahamas. And so that's exciting. You're all the first international market for us. But the fact that some of you have had experience with it already in your clinics, through the whole effort that we've done with Barry University and some of the outreach down there, is exciting. So again, thank you for your time. Thanks for your attention, and good luck in all you do. And I hope to see you all again soon. And I hope our paths do cross in person again. Thank you very much.